Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In the previous video, I talked about the initial assessment, management, and monitoring of patients with traumatic brain injury at the scene, during transport, and at the emergency department before admission to intensive care unit. I'll put the link in the description below in case you're interested. In this video, I'd like to discuss the indications for neurospecialty referral, causes and pathophysiology of primary and secondary brain injury, and assessment for decision-making to admit patients with severe traumatic brain injury to neuro-intensive care unit. After traumatic brain injury, we need to triage the patients according to local guidelines and policies, and select the ones who could potentially benefit from referral to neurosurgical hospital and trauma center. The general idea is the patients with coma, abnormal pupils, evidence of mass lesions which are potentially evolving, diffuse swelling, early traumatic brain contusion, traumatic SH on imagings, or simultaneous multiple bone fractures should be referred to trauma centers and discussed with specialist neurosurgeons and neurointensivists as required. If urgent surgical intervention is advised, and if the patients are not already at trauma centers, we need to arrange and ensure the safe transfer of the patients after liaising with specialist teams. Now, let's talk about primary and secondary brain injuries. The clinical outcome after head injury depends on both primary and secondary brain damage. Unfortunately, there is no effective treatment for primary brain damage, but prevention and effective treatment of secondary insults to the brain are the major factors in management of traumatic brain injury. Quite often, primary and secondary brain injury cannot be clearly distinguished from each other. The relationship between primary and secondary brain injuries and their potential sequelae will ultimately result in cerebral ischemia and cell death. Primary brain injury results from the direct mechanical trauma at the scene of the accident, leading to brain vessel and parenchymal damages causing hemorrhagic contusion and neuronal damages causing traumatic or diffuse axonal injury. Secondary brain injury could be due to extracranial or intracranial causes. Hypoxemia, hypercapnia, systemic hypotension, anemia, deranged blood coagulation, and infection are notorious extracranial causes. Intracranial causes include intracranial hematoma, cerebral edema, uncontrolled seizure activities, and intracranial infections. Secondary brain injuries are independent predictors of poor outcome with increased risk of mortality, and they are mainly associated with cardiopulmonary instabilities and raised intracranial pressure, which are often avoidable by maintaining cerebral oxygen delivery, controlling any source of bleeding, and achieving adequate cerebral perfusion pressure between 60 and 70 mm mercury with proper control of intracranial hypertension and aim of higher mean arterial pressure. As we have had a bit idea of the intracranial causes of secondary brain injury, then I would like to discuss the pathological effects of intracranial lesions in traumatic brain injury. In traumatic brain injury, parenchymal lesions are by far the most frequent lesions. Traumatic contusion is an irreversible damage of the brain tissue, subsequently caused by head trauma. Hemorrhagic transformation within this contusion area could lead to larger traumatic hematoma. One of the most common problems after severe head injury is the mass effect of developing focal lesions compressing intracranial structures, mainly the brain. Intracerebral hematomas, for example, supratentorial hematomas, initially put pressure on subarachnoid space and lateral ventricles on the same side. Then shift it to the opposite side. After that, they could compress and displace the third ventricle, leading to transtentorial herniation of the medial temporal lobe, and finally squashing the areas surrounding the brainstem, resulting in herniation, which is known as coning. The effect of that space-occupying lesion is directly proportionate to its size. Interestingly, Patients with brain atrophy, like in elderly and alcoholics, have more intracranial space, so they could tolerate hematomas more than younger patients. If the hematoma is located in the posterior fossa, it has lesser space to expand, so such hematoma requires more urgent attention to be sorted. CT evidence of traumatic subarachnoid hemorrhage, especially if located above the cortex, could be a warning sign for potentially evolving cortical lesions which bleed into the subarachnoid space. Extradural or epidural hematoma, EDH, is an accumulation of blood in the epidural space between the inner side of the skull and the dura mater. It's usually caused by scar fracture crossing the middle meningeal artery or its branches in the frontotemporal region of the brain. We should bear in mind that patients with a scar fracture may be neurologically intact on admission and later conscious level deteriorates as the EDH develops. We call it lucid interval, and we need to be very careful to discharge such patients home. EDH is quite uncommon in the children less than 5 years old and the elderly of more than 65 years because the dura is tightly adherent to the skull and it does not tear easily. Subdural hematoma, SDH, is an accumulation of blood between the dura and the arachnoid layers of the brain. It results from torn cortical vessels following large contusion at the frontal or temporal surface of the brain in most cases. Subdural hematomas are called acute if developed within the first 24 hours, subacute if between 1 and 7 days, and chronic if more than 7 days. Patients with SDH have worse prognosis than those of EDH. They usually become unconscious straight away after head injury. Additional neurological deterioration could occur with the expanding hematoma. SDH is more common in patients with atrophic brain. In association with intracranial hematomas, skull fractures are a common finding in head injury. If the fracture is closed and not depressed, specific treatment is unlikely to be required and healing occurs spontaneously. On the other hand, open and depressed fractures would usually need neurosurgical intervention. About 25% of patients with severe head injury have operable intracranial hematomas. The final decision whether and when to operate the patients lie on neurosurgeons based on a variety of factors such as mass effect of the lesions, their location on CT scan, neurological and general conditions of the patients. If patients with severe head injury present with deep coma despite normal CT head scan, it could be due to traumatic axonal injury, TAI, without any intracranial mass, which could occur in almost 50% of such patients. Severe TAI means widespread damage to axons microscopically and is often associated with scattered microhemorrhages along or near the midline. The extent and distribution of TAI could reflect the prognosis of brain injury. MRI scan could reveal the cerebral damage and edema, which could not be identified by CT scan. Brainstem is a vulnerable intracranial structure, and once affected, it could be related to poor outcome. Brainstem could be injured secondary to supratentorial herniation or traumatic axonal injury, as I mentioned earlier. Moreover, it could be part of severe diffuse brain injury or isolated injury without any correlation to other brain injury. MRI head can easily detect any brainstem involvement after traumatic brain injury. Following severe head trauma, due to primary or secondary brain injury, cerebral ischemia could cause ischemic penumbra, that is, functionally impaired yet still viable tissue, or irreversible cerebral infarction, both of which are recognizable on CT head. Post-traumatic cerebral infarction can be classified as territorial cerebral infarction, which can be seen as hypodense lesions well limited within a defined cerebrovascular territory. Watershed cerebral infarction, which is located in boundary zones between anterior, middle, and posterior cerebral artery territories or in terminal zones of perforating arteries, and non-territorial, non-watershed cerebral infarction, which is single or multiple hypodense lesions without any precise localizations in a vascular territory. Generally, post-traumatic cerebral infarction is associated with more intracranial hypertension and with a poorer prognosis. Not only arterial infarction, post-traumatic venous infarction with atypical hemorrhage and large volume edema may occur due to thrombosis of intracerebral sinuses and veins related to scalp or fractures. Clinically, it is frequently associated with seizures, which could worsen intracranial hypertension. Diagnosis should be confirmed by CT or MR angiogram. Cerebral edema is an unwanted reaction of the brain to severe head trauma. It usually develops during the first 3 to 5 days, and also it could give rise to increase in intracranial pressure, leading to reduced cerebral blood flow, which could result in further cerebral ischemia, so creating a vicious cycle. Patients with head injuries commonly have different types of cerebral edema, such as cytotoxic cerebral edema, which is initial and central due to brain tissue injury, vasogenic cerebral edema, which enlarges from the center over days, and osmotic cerebral edema, where water is drawn into affected area by the high osmotic forces of the damaged brain tissue. Likewise, if the trauma is extremely severe, diffuse cerebral edema could occur. The Glasgow Coma Scale, GCS, is one of the most commonly used clinical scoring systems to determine severity of brain injury, which is designed to assess conscious level, mainly motor responses. I've made a video about GCS scoring in detail, so if you're interested, please click the link in the description below. Patients with GCS scores of 3 to 8 are regarded as severe traumatic brain injury, 9 to 12 as moderate traumatic brain injury, 13 to 15 as mild traumatic brain injury. Patients with severe traumatic brain injury require intensive care admission, ideally to neurotrauma ICU. Patients with moderate brain injury should also be on the radar of intensive care team, for example, critical care outreach team, for close monitoring in case there is any decline in neurological status, or airway compromise, or any evolution of intracranial lesion. In addition to GCS, brainstem reflexes and full neurological examination should be done as well. Normal neurological status on admission does not always rule out significant brain pathology. Even if the CT scan is negative, intracranial hemorrhage can arise or enlarge even days after the injury. Therefore, a repeated CT scan is recommended in all patients with severe or moderate injury within 6 hours after the initial CT scan, especially if they are on blood thinners. That's it for me in this video. Hope you have picked up something new. If you have, please share with your friends and colleagues. In the next video, I will discuss the advanced neuromonitoring, management, and complications of patients with severe traumatic brain injury in neurointensive care unit. I'll see you later. Take care.